Assalamu alaikum and welcome to our second lecture on thyroid disorders. We have partly covered the workup of a thyroid nodule in the previous lecture, and as we said, that is usually more commonly presents to the surgical department. But of course, the toxic adenoma would require an initial assessment by a physician that whether the gland is uh, hyperactive or not, and that workup definitely has to be done by a physician. Uh, we'll talk as usual in a format of case presentation and case scenario followed by. Now, this is a beautiful evening captured some 7-8 years ago in Frankfurt. This is River Rhine. The case scenario is of a 45-year-old male who was reported in OPD of Mayo Hospital, uh, which was the following complaints: that he's lost around 12 kg of his weight over the past 6 months. He feels embarrassed because of his always shaky hands and sweaty palms. His wife reports him being feverish all the time. He's anxious. He has lost his sleep and is insomniac. He's restless and can't sit idle for a few minutes. He always feels hungry and gets agitated over petty matters. He sleeps without a quilt or a blanket in the winter and passes 3 to 4 stools in a day, which are well formed. And he's also a smoker and smokes around 20 cigarettes a day. On examination of this gentleman, his weight was 45 kg. He had a pulse of around 104 per minute, which was regular and forceful bounding pulse, with a blood pressure of 150 over 90 millimeter of mercury. His temperature at that time recorded was 99 degree Fahrenheit, and he had warm and moist hands. He had some fine tremors of outstretched hands, and a faint grade 2 systolic murmur was heard all over the precordium. This is his picture, which was shared with his consent. And the most prominent thing to be noticeable was very unduly prominent proptosed eyeballs, in fact. And then, so this face examination was suggesting that he has proptosis, he has lid retraction, he has lid lag. There was some exposure keratitis, and then Mobius signs were positive. One by one, we just say elaborate on these physical findings. You say proptosis when your eyeballs are bulging out, and you can see either the sclera uh, above the cornea in a normal resting stare or position, or more say accurately, you measure it by asking the patient to lie down and getting onto the head end of that patient, and kneeling down to the forehead level of the patients. And if you see the eyeballs protruding say above or in more than the superior orbital ridge, this does suggest proptosis, and this can be ophthalmology people can probably accurately measure that how much this eyes is proptosing beyond this superior orbital ridge. To check for lid retraction, you ask your patient to be sitting at the eye level on a stool or in a chair, and you move your finger about 1 meter distance from the patient in front of him, and you move it in a primary position. If you notice that you can see the sclera above the cornea. Normally, in a resting position, your patient usually has the upper lid covering a bit of, say, cornea, and the sclera above the cornea is not visible. But if you can see a patient's sclera uh, above the cornea or white area above the cornea in a normal sitting position, it means that his eyes are been protruded outward, or and there is the lid has been retracted. In the same fashion, if you ask your patient to move his gaze downward, that you ask your patient to move his this eye in front of him, and then you move it downward in front of that. Uh, Normally, the eyelids follows the movement of the eyeball, and you don't see any sclera visible when patient is looking downward. But in a patient who has a proptosed eye, he would have his sclera becoming visible as the lid lags behind the movement of the eyeball. So this is lid lag. By exposure keratitis, we mean that if your patient is not able to, say, fully close his eyelids and cover the cornea, there would be some dust particles or other material probably would be irritating the eyes, and this would lead on to some damage to the cornea, leading on to the corneal damage in the or inflammation in the form of keratitis and some redness of the eyes. Now, the Mobius sign is again when you have a lot of, say, soft tissues growth around the eyeballs. The movement of the eyeball from side to side also becomes affected. And you ask your patient to uh, move closer. You ask him to look at a distance, and then you move his your finger to the tip of his nose and ask him to focus on it. Normally, the eyeballs should converge medially, but because of this large eyeballs, they can't converge, and the failure of this convergence on looking near is called Mobius signs. This was the examination of this person's neck, and you can notice the arrow has been clearly defined, that there is a visible rounded nodule visible in front of his neck, more to the right side, or maybe in the right lobe of the thyroid. Again, normally what do? You ask your patient to have, say, to swallow his saliva or have a sip of water being swallowed. And this nodule, if it is arising from the thyroid and it is within the thyroid fascia, it would move up along with the movement of the larynx. While if it is arising from subcutaneous tissues or is a lymph node, it would stay at its place and it would not move. So in examining the thyroid, you first inspect it for any swelling around this area, which is the area around the larynx, which is of the thyroid area. And then if there is any protuberance or any nodularity, as in this case, then you ask your patient to have, say, swallow or saliva or sip of water, and this with the movement, the larynx would move up, and similarly, the swelling would move up as well. But if it is from the subcutaneous tissue or somewhere else, it would not move up. Now, this patient had this visibly, say, nodular swelling visible, and it was also moving up along with the swallowing. So there is on palpation, there was a firm nodule in the right lobe of the thyroid. It was not tender, mobile with deglutition. Skin overlying it was not fixed to it. There was no lymph node enlargement, no audible bruit over thyroid or carotids. So what do you diagnose? So clinically, we diagnose it that there is a palpable thyroid nodule in the right lobe, and along with that, as we have already narrated, this patient has signs and symptoms suggestive of hyperthyroidism or thyrotoxicosis, and that's why that this combined together, we call this patient as a toxic nodule in his thyroid, because most of the features this gentleman has, starting from the agitational mood to palpitation to increased sweating to increased weight loss to increased say appetite, and then coupled with the physical sign we demonstrated, are in favor of say hyperthyroidism, and this is toxic nodule of the thyroid. So this is a toxic adenoma of the thyroid. How this should be investigated? Of course, the first and foremost investigation probably would be that doing an ultrasound on the neck and look for this, whether this nodule is soft cystic or solid. The ultrasound would tell us the cystic nodules are likely to be benign and solid nodules are likely to be malignant or maybe more of adenomatous. Second investigation would be that we check this person thyroid hormonal assay, which we check uh, free T3, free T4, and thyroid stimulating hormone. Now, this would tell us whether this patient has primary hyperthyroidism or not, and the combination would be that T3 and T4 would be elevated and TSH would be suppressed. Next online would be that we go for a thyroid scan. Now, thyroid scan, as in previous lecture we explained, that a thyroid scan would lead on to uh, delineate that what is the status of iodine uptake by the gland. Normally, you have a very smooth and say well spread thyroid uptake by the gland, which we did show the pictures that it would be evenly distributed in both the lobes. But in case of a toxic nodule, since it is concentrating the iodine more into that adenoma or into that nodule, this single nodule would have a increased uptake to an extent that there would be more dense uptake in the nodule, when the surrounding tissue would have a suppressed the iodine uptake. And this again, thyroid scan would show us the in a picture form that whether this iodine is concentrated to its particular area, and the uptake would tell us that what is the pattern of uptake, that whether it is taken up in all in the initial few hours of administration of iodine, or whether it is a slowly delayed uptake. In a toxic nodules or toxic goiters, the we call it that is a hungry thyroids. So the most of the uptake is in the early part of the iodine administration. Now there is another say terminology used for such patients, which is those who have a toxic nodular goiter in the thyroid gland, and that contains autonomously functioning thyroid nodules with the resulting hyperthyroidism. So the Plummer disease is another name given to this toxic adenoma of the thyroid. The most common cause of hyperthyroidism in elderly patient is usually this single toxic nodule. This autonomously functioning nodules may become toxic in 10% of the patients, and hyperthyroidism usually occurs when the single nodules are larger than 2.5 centimeters. So, in other way, you may have these adenomas which are normally functioning or not hyper functioning, and usually if their size is less than 2 centimeters, they have say not showing any signs of toxicity, they can be left as such. But some of these nodules, when they grow bigger in size, they also become autonomous. By autonomous mean that they are not under the effect of pituitary or thyroid stimulating hormone, and they start behaving as if they start producing this thyroxine at their own, and that's why that is hyperthyroidism takes place. Toxinol goiter usually accounts for almost 58% of the cases of hyperthyroidism. So that's quite a big number. That when you talk of hyperthyroidism, we usually think that it could be maybe an autoimmune type of thyroiditis or Graves' disease, which are usually more common. But look at it. It is the toxic adenoma which is more likely to be responsible for hyperthyroidism, and particularly so in the elderly or middle-aged group. What are the signs and symptoms? We have already described. There would be thyrotoxic symptoms. Sometimes these patients, particularly the elderly patients, usually have not classical hyperthyroidism in the form of, as we said, tachycardia, palpitation, or anxiety and all that. In fact, they are more like, say, depressed or more like apathetic. So this is not unusual to have these patients having uh, apathetic hyperthyroid, where the lab values are definitely suggesting that patient is hyperthyroid, but clinical sign symptoms, except for that nodule, are not there. Rarely, these adenomas can be big enough to cause compression of the trachea or compression of the esophagus, and they may present with obstructive symptoms, sometimes with stridor, sometimes with difficulty in breathing, sometimes difficulty in swallowing, and many a times they may be asymptomatic, and their first presentation may be this high hyperthyroidism, possibly causing atrial tachycardias or atrial fibrillation. Thyrotoxic symptoms usually, as we said, majority of them would present with heat intolerance, palpitation, tremor, weight loss, increased hunger, and sometimes frequent bowel movements. More frequent would be called as hyperdefecation rather than labeled as diarrhea. As we said, in elderly, the symptoms are usually atypical. In them, unexplained weight loss may be the most common complaint. Sometimes instead of, say, increased appetite, they will have anorexia and constipation as opposed to the diarrhea, which is more common in young people. Dyspnea or palpitation are more common in these individuals, of course, particularly when they have tachycardia or when they have atrial fibrillation resulting from hyperthyroidism. Tremor sometimes are say confused with that. This is essential because we know that with aging you do have some senile tremor setting in, and many a time these senile tremors are mistakenly say not considered as that they are because of hyperthyroidism. Again, the cardiovascular complications like atrial fibrillation, congestive heart failure, angina would be more common in elderly patients having a toxic adenoma or thyrotoxicosis as compared to the younger individual. We did talk about this Lahe was the physician or scientist who first described and there is an apathetic form of hyperthyroidism as well as back as 1931. Now, this is correctly blunted effect or lack of hyperkinetic motor activity and slowed mentation in people, patient, particularly elderly, who are actually thyrotoxic. A large substernal goiter or a nodule may cause dysphagia, dyspnea, as we already, and sometimes frank stridor may be there, and rarely this goiter results may result in a surgical emergency. So, involvement of a recurrent or severe laryngeal nerve may result in complaints of hoarseness or voice change. And we did talk about that some of these patients, despite all this, may be asymptomatic. And maybe they may be incidentally found to have hyperthyroidism during routine screening. The most common laboratory finding is usually, as we said, suppressed TSH with normal free thyroxine levels, or you may call them as subclinical form of hyperthyroidism. How it all develops? It says that usually to begin with, the generation of this nodule is as a result of iodine deficiency. So there is iodine deficiency, there are low level of the thyroxine, and then there is a compensatory thyroid hyperplasia because of the raised thyroid stimulating hormone from the pituitary. Now this thyroid stimulating hormone leads on to hypertrophy thyroid. We also get a thyrotrophic release, say hormone, and this lead on to increased thyroid cell replication, and some of these cells which are under the effect of this thyroid stimulating hormone trying to perform more, they undergo some somatic change in the thyroid stimulating hormone receptors. Now, this mutation of this TSH receptors and G-alpha protein confer constitutive activation of cyclic AMP cascade of the inositol phosphate pathways, and these mutations then are responsible of these thyroid cells becoming autonomous and losing the control by the thyroid stimulating hormone, and this then this keep on mutating and say dividing and take on the form of an adenoma. How should these be investigated? As we had already described, serum T3, T4 and TSH would be done. T3 and T4 would be elevated and TSH would be suppressed in a more overt form of hyperthyroidism with these adenomas. And sometime in subclinical form, you would only have suppression of TSH, but T3, T4 may be like normal or near normal. Thyroid scan we already described. Ultrasonography of the neck to look for whether it's solid or cystic. Sometimes we have to go for CT scan of the neck and thorax to look for its retrosternal extent, to look for any renal lymph node, and look for any, say, nodule being single or multiple. FNAC would be required to look for that whether this is a functional normal thyroid tissue or this adenoma might have gone some malignant transformation. ECG would tell us about tachycardia and atrial fibrillation, or when we are talking of elderly population developing these nodules and getting atrial fibrillation and have worsening of their heart failure, the underlying heart disease like an pre-existing coronary artery disease or previous infarct may be seen on ECG. CBC ESR usually would be normal except for say in some inflammatory conditions. These patients are likely to become, say, unmask their diabetes, and they may be euglycemic previously. They may be not known diabetic previously, but with the onset of this toxic symptoms because of the thyroid thyroxine again being something which probably increase the metabolism and can lead on to unmasking their diabetes, and they may become manifest diabetics. The treatment of this toxic adenoma usually can be in the form of either medication or drugs, or you can have radioiodine, say applications or administration, and then the surgical option. Antithyroid drugs and beta blockers are used for short courses in the treatment of toxic nodular goiter. They may render the patient euthyroid in preparations for the radioiodine or surgery. Now, to treat the hyperthyroidism while waiting for full clinical response to radioiodine. So, in the beginning, you want these patients to have some control of their heart rate by use of beta blockers, and there may be some, say, antithyroid drugs may lead on to suppression of synthesis of the hormone by this nodule which has gone autonomous, and this, once your patient have achieved a near normal or euthyroid stage, then it would be better to either administer them radioiodine or to undergo surgery. The medication we use are these three: propylthiouracil in the dose of 100 to 400 milligram per day. Propylthiouracil is can be safely given in pregnant women as well, whereas carbimazole can't be given. Carbimazole in a dose of 10 to 40 milligram per day, but remember this being teratogenic, should not be given to female who are either pregnant or are say planning to have pregnancy in near future. Propranolol is a beta blocker, and its primary function is one to decrease the heart rate, and somehow there is this beta blockers also lead on to, say, blockage of conversion of T4 to T3 in the periphery. So they would also lead on to some improvement as a result of hyper secretion of the thyroxine. Radioiodine therapy, again, radioiodine usually so sodium 131 iodine treatment is more preferentially done in US and Europe, and this is considered treatment of choice for this toxic nodular goiter. This should not be or cannot be given in pregnant women because, of course, it's say potential to cause teratogenicity and the fetal malfunction or malformation. Sorry, and there are otherwise no contraindication for this radioiodine therapy. Usually, a single dose of radioiodine therapy has a success rate of around 85 to 90% in patients with toxic nodular goiter. This radioiodine therapy may reduce the size of the goiter by up to 40% in most of the cases, but this is not hazard free. Complications of radioiodine include that this would lead on to not only the destruction of the uh, hyperactive nodule but of the surrounding normal tissues as well. Of course, since this toxic nodule is the one which is concentrating all the iodine coming to it for manufacturing thyroxine, and this is also lost the control by the pituitary or by the TSH. So majority of the iodine would be concentrated in the nodule, and very less would be going to the, but still the one which is taken up by the normal thyroid gland would render them, say, hypothyroid as well. So this is one side effect, that the patient may become hypothyroid and then may have to be treated with the supplemental thyroxine maybe for lifelong. Similarly, when you give radioiodine, there is, of course, an increased uptake by the glands, particularly the nodule or the toxic adenoma cells. So there is a lot of sort of inflammation caused by that, and this inflammation leads to a further release of the thyroxine from these nodules. So there is maybe a transient phase of uh, aggravation of their hyperthyroid symptoms or thyrotoxic symptoms. That's why that even before you consider radioiodine, say therapy or application, you want these patients to be euthyroid by giving them antithyroid drugs. Again, the point is that if your patient is already on antithyroid drugs, how do these carbimazoles or propylthiouracil work? They work through the, say, blockade of uptake of the iodine by the cells. Now, if your patient is already taking antithyroid drugs, when you give radioiodine, this its uptake would also be blocked. That's why that you in patients who are to undergo radioiodine therapy, if they are on antithyroid drugs previously, their antithyroid drugs has to be stopped for a while, maybe 1 to 2 weeks, right? And because this they have a longer half life and they may still be in circulation. And if your patient is already on antithyroid drugs, the radioiodine say given would not be taken up by the glands, and the patient, it would become useless. So when these patients are being considered for radioiodine therapy, their antithyroid drugs, carbimazoles, have to be stopped. Uh, Again, this not only that this would lead on to, say, some thyrotoxic symptoms in the beginning after the administration of radioiodine, but this can start on the inflammatory response in the gland and may lead on to radiation-induced thyroiditis, again worsening the underlying hyperthyroidism. The elderly patients may have an exacerbation of congestive cardiac failure or atrial fibrillation resulting from this thyroiditis or transient hyperthyroid state, which usually they get after the adrenal thyroid. And these patients, that's why the particularly the elderly patient have to be pre-treated with antithyroid drugs before they are considered for radioiodine therapy. So the 3 or 4 things which radioiodine therapy can say do, we can start off with. One, uh, first you have to render your patient euthyroid before you apply uh, or consider them giving radioiodine. Two, you have to stop it for about 2 weeks before the administration of radioiodine. Three, this radioiodine administration can result in a transient exacerbation of hyperthyroid symptoms, for which you have to be prepared. Again, 4 to 5% of these patients may develop thyroiditis, and finally, 10 to 20% of these patients may develop a permanent hypothyroidism, which then would require treatment. Another complication would be thyroid storm. Again, that is an excessive thyroid hormone release and leading on to hyperpyrexia and other symptoms which we will be discussing in some next lecture. Surgery for thyroid adenoma is reserved for younger individuals, right? Or those who have more than one large nodules, or who have some obstructive symptoms resulting from that, or patient with the dominant non-functioning or suspicious nodules. Uh, Again, it can be also be considered for pregnant who have thyrotoxic symptoms and are not candidate or should not be subjected to radioiodine, or should not be subjected to even say antithyroid drugs like carbimazole. Or if you have previously tried radioiodine therapy and it has failed, now these may be considered for surgery. Or similarly, if we want a very rapid resolution of the thyrotoxic symptoms, surgery would be more appropriate option, because as we already seen that drugs take quite some time to work, and radioiodine again has a risk of having a further transient hyperthyroid state after its administration. Thyroid storm is a state of an extreme hyperthyroid state, which is usually seen as a complication of toxic goiter surgery during intraoperative and postoperative stage, or as a result of intercontinuous in hyperthyroid patient. So if you're a patient who have previously known to have thyrotoxicosis or hyperthyroidism, either because of an adenoma or because of a single hyperfunctioning hot nodule, when they are subjected to, when they develop some intercontinuous infection, this nodule may become, say, start producing excessive amount of thyroxine releasing into circulation, and this excessive circulating thyroxine would lead on to an extreme state of hyperthyroidism. Similarly, when during the surgery, when you make an incision and when you try to handle this nodule peroperatively during operation, you lead on to quite a bit of release of hormone from this nodule into the circulation, and this high surge of thyroxine would lead on to state of a very acute severe hyperthyroid state, and this is what is called as a thyroid storm. It's a fulminatic state and can be itself fatal if not treated, and the mortality is quite high. So every effort has to be made this patient to be, say, euthyroid prior to surgery and maintained in a euthyroid stage immediately peroperatively or postoperatively. Now this is the comparison of the clinical picture that can happen in a patient with a thyrotoxic state and when he goes into a thyroid storm. Of course, we know that heat intolerance and increased sweating are symptoms, but in patient who undergoes thyroid storm or severe hyperthyroid state, there is hyperpyrexia. And in uncomplicated thyrotoxic temperature is usually 99 or so. But in thyroid storm, the patient may have temperature rising up to 106 degree Fahrenheit, not centigrade, sorry, and and that they would be having quite a bit of dehydration, lot of sweating. The rate in uncomplicated thyroid is usually sinus tachycardia, heart rate varying from 100 to 140. But in thyroid storm, the heart rate is much faster, maybe more than 140 beats per minute. Patient would develop hypotension and they may develop atrial dysrhythmias or atrial fibrillation. And of course, the elderly patient with an underlying or coexisting cardiac condition may develop frank congestive cardiac heart failure symptoms. In uncomplicated thyrotoxicosis, usually your patients have diarrhea or increased appetite and loss of weight. But thyroid storm patients have nausea, vomiting, their diarrhea may be very excessive, they may have abdominal pain, And of course, there is hepatocellular dysfunction, and some of them may develop jaundice as well. The patients in uncomplicated thyroiditis may have some anxiety or restlessness, but thyroidostorm patients, in fact, become confused, agitated, they become delirious. They may have a frank psychosis, sometimes they have seizures, and they have stupor or coma. Look at the thyroid storm, in fact, is one of the emergency situation in patients with hyperthyroidism. It can happen in uh, hyperthyroid patient who have other concurrent illness or chest infection or UTI or whatever, or more commonly when they are subjected to surgery, and during surgery or perioperatively and postoperatively they developed hyperpyrexia, tachycardia, worsening of their heart failure, and confusional state, and sometimes even jaundice as well. This is the criteria which is, say, put on by Burch and Wartofsky. And what does it say? The patient, if they have hyperpyrexia starting from 99 to 104, so you give them 5 to 30 points, 5 points for each degree, say, Fahrenheit rise in temperature would be considered, right? So for 91, 99 would have 5, 10, 100 would have 10, 101 would have 115, and so forth. Similarly, altered mental state starting from mild, moderate to severe would have 10 points each, and the maximum would be 30. A cardiac dysfunction, the heart rate increase from 90 to 140 again would have 5 points for each 10-degree rise in the pulse rate. Uh, Congestive heart failure, mild, moderate, severe, assessed by the clinical examination may have 5 to 15 points, and once someone have atrial fibrillation, it has 10 points. And if you have precipitating events like surgery or cold infection, 10 points. So anyone having a total score of aggregate of more than 45 points in this setting of a thyroid nodule or a previous hyperthyroid would be considered for uh, diagnosis as thyroid storm. The thyroid storm diagnosis is usually the TSH is low, T3, T4 would be raised, there would be elevated 24-hour radio-iodine uptake, there is increased BUN creatinine because of dehydration and perirenal azotemia. There are electrolyte imbalances, particularly hyponatremia, as a result of dehydration. These patients may have some degree of anemia, thrombocytopenia, and sometimes marked like leukocytosis. Their ALT, AST, LDH, and alkaline phosphatase and bilirubin are elevated. They may have some elevated calcium levels, and not to forget, some of them may have hyperglycemia as well. Thyroid storm, as we said, is a medical emergency. So how do you treat? You definitely admit these patients for close clinical monitoring and supportive care. The specific treatment is administration of anti-thyroid drugs. You have to treat the precipitating cause. If there is infection, you treat it with antibiotic. If there is renal, say, dysfunction, you treat it accordingly. And then, of course, the underlying cause, whether it is a thyrotoxic nodule or whether it's a diffuse thyroid or Graves' disease. So the step-by-step thyroid storm treatment, the drug of choice would be propylthiouracil in the dose of 200 to 400 milligram every 6 to 8 hourly. Iodine, again, when you increase the iodine intake, it prevents the release of the hormones, and you can give uh, this iodine before 1 hour after, sorry, propylthiouracil, and it can be given in the form of sodium iodide 1 to 2 gram per day, or maybe SSKI or potassium iodide drops every 6 hourly, 5 drops every 6 hourly. You give them beta blockers, preferably they have to be given in intravenous form, maybe from 1 to 5 milligram up to 20 to 40 milligram every 4 hours. There is an increased demand of hydrocortisone as a result of the whole of the body metabolism. going up, and the requirement for hydrocortisone, so they would be given steroids 100 milligram every 6 hourly. And sometime you might have to, there is an increased release of antibodies which is responsible for stimulating the thyroid gland. So plasmapheresis would lead on to not only removal of these antibodies but also removal of the excessive circulating thyroxine from the blood as well. And of course the supporting care in the form of IV fluids, antipyretics, digoxin for heart rate control in those who have atrial fibrillation would be required for treatment. So that's all for the management of toxic adenoma of the mm, thyroid, and resulting in showing uh, extreme hyperthyroid state, which would be called as a thyroid storm. And that's all for today. And the next time we'll be going on for Graves' disease and other cause of hyperthyroidism. Thank you.